call, if you could do the roll call, please.
Sure, and we will do a verbal roll call. So when I call your name, please confirm your attendance. Shauna Janeway sitting in for Dave Sanders.
I'm here. Am I close enough to the mic? Can you hear me?
I believe so. For those, yeah, I'm getting some yes nods, so it sounds good on verbal. Just a reminder, if everyone could speak into the mic for those that are participating hybrid. Next is Marlene Fonseca.
Here.
Chad Boggio.
Here.
Gary Glaze.
Here.
Dana Brown.
Here.
Tony Royster.
Here.
Matt Zabo.
Here.
Hetty Santos sitting in for Holly Walcott.
Here.
That's 4 members labor, 4 members management, and a quorum.
All right, thank you. You know what? I don't have the. Sorry. Thank you so much. All right. Okay, so, do we have any public comment?
If anybody is attending remotely and would like to make a public comment, please press *9 on your phone to be able to put yourself in the queue. Seeing none and hearing none.
All right, thank you so much. So we have 4 sets of minutes. You want to take over?
My apologies. Carry on. Where we are on agenda call.
Oh, we're on item number 3.
Have we turned it over to you?
Uh,
Minutes recommended to approve the minutes. Item number 3, right? Is there a motion to approve?
I move to approve the minute.
Second. Moved in second, all in favor?
we do still have to do a roll call vote, so we'll do in the same order. And we'll start with you, Dave. Dave, your vote.
Yes.
Marlene, your vote.
Aye.
Chad, your vote.
Aye.
Gary, your vote.
Aye.
Dana, your vote.
Aye.
Tony, your vote.
Aye.
Matt Zabo, your vote.
Aye.
And Petty, your vote.
Aye.
It's unanimous. The motion passes.
Thank you, sir. Item number 4, committee report 2315, the vision plan service request for proposal, findings and recommendations. Good morning, sir.
Good morning. This is Ted Vasquez of the Employee Benefits Division, along with my colleague Roby Ann Jamaus, and from the city's consultant Keenan, Megan Gardner will be presenting this report. I'll begin with a quick recap, quick summary of the RFP and the RFP services. The RFP was released to the vendor community on December 29, 2022, with the response deadline of February 15, 2023. And the RFP sought to procure fully insured vision plan benefits for its civilian LA Well benefits program that included the following: quality vision care services that match or expand the current vision plan services, access to services across the Los Angeles region with minimal provider disruption to existing patient-provider relationships, optimized premium costs over multiple years, and customer services and self-service tools that assist members in navigating these vision benefits. Now, 2 proposals were submitted by the deadline, one from Anthem and one from MetLife. And both submitted proposals were evaluated and scored by the review committee, which included myself and Roby Ann, and by the city's consultant Keenan as a peer review only. So on page 4, we've outlined our evaluation approach. The RFP posed 115 questions over a range of 6 categories. Each category was assigned a factor weight and either a qualitative or a quantitative evaluation method. And the evaluation ratings were based on the review committee members' assessment of the response as supported by the analysis as performed by Keenan. And the qualitative and quantitative evaluation determination categories and their associated indicators are provided on the report on page 5 and 6. Now, on page 7, beginning on page 7, we provided a summary of the submitted proposals. In general, both proposals had many similarities, and the 2 proposals were deemed as qualifying for consideration, with each proposer meeting the minimum qualifications asked of the RFP and demonstrating compliance of general contracting requirements. Now, on page 10, we've summarized some of the notable differences between the 2 proposals, with the majority of those differences being in the categories of access, continuity of care, and financial cost and benefit design. And to discuss these differences in greater detail, I'll pass it over to Megan.
Good morning, distinguished members of the JLMBC committee. I'm Megan Gardner, and my colleague Borden Darm is actually joining us virtually. He is our lead technical consultant. And just by way of background, we did analyze the proposals that were received as they relate to your current program. Now, your current program has been in place since 2017. Prior to that time, your vision care benefits were part and parcel of your medical plan. They were carved out into their own plan, and IMED has been your carrier since that time. IMED has had the contract. Their contract will be ending at the end of the year. You are on a composite rate for your premium rates, and over the years, as they've been your partner, we've done renewals and things that have been very favorable for the city. Most notably, last year in July, IMED 360 was implemented and provided a greater benefit to employees who utilize providers who were part of the Provider Plus program. All that was taken into consideration as we looked at the two proposals that were received as a match to current, which obviously impacts, premium rates. Plan design are derived into premium rates, as well as experience, the provider match, geo access, and disruption. And we have summarized this in the report itself, but I do want to turn it over to Borden. Borden, are you there to talk a little bit about the financial before we discuss geo access and disruption?
Yes, I'm here. Can you hear me?
Yes.
Okay, can we move to the financial section?
Which page would you like to go to?
The summary page between the two.
Or is that?
Yeah, there we go. Of course, now it's an eye test for me because I'm looking at it on my laptop. Is it possible to enlarge that page?
What?
It's so small.
Yeah. Okay. So what we wow. Okay. And if we move down the page to at the top of the page, we have each proposal that we received. The first one is not a proposal, but first column is IMED, what you currently have, and we go through the plan design to ensure that the appropriate plan design features were provided. As we move down the page and we get past the plan designs, we'll see some financials. And that's fine there. And as you can see, currently we have a little over 25,000 subscribers with a composite rate of $9.17. So composite rate means regardless of whether the coverage is for employee only or employee plus family, the rate has been composited into one single rate. That works out to about $230,000 a month, 2.765 million on the year. Then as we look at the proposals, I believe the second two columns are the what was proposed by Anthem.
Correct.
And thank you. And you can see that for one of the big differences between the two proposals, and if you could go to the top of that page real quick, I believe it says it in the heading. Okay, the first proposal matches the current plan design, and on the second proposal matches the current plan design with an increase for contacts allowance to $175 a year. So that's the difference, is just the contact allowance. And if we go back to the bottom of the page, you can see that for the first proposal from Anthem, they matched at $9.17. So the same pricing as is current. And for the enhanced benefit option or option 2 under Anthem, It's a slight increase to $9.85, or an increase of 7.4% or $205,000 on the year. Are there any questions on Anthem's proposal? If not, then I'll go into our second. Thank you. And MetLife did the same thing, provided two options. One, with the same plan design, and the second option with an increase in the contact allowance to 175. At the top here, you see the plan design comparisons. And then as we go to the bottom, thank you. You see that MetLife comes with a 2% rate decrease, or $8.99 composite, for a $54,000 annual savings. And on with the contact lens and allowance, it's $9.52, $9.52, or a 3.8% or $105,000 increase. And that concludes really the financials of the two proposals that we received.
So both of those proposals that Gordon just reviewed were on a fully insured basis. One of the options that we looked at as part of the process of doing the due diligence with respect to the program was also the option of self-funding the coverage. Those proposals were also analyzed and are included in the attachment A supplement to the JLMBC report that we've provided, and follows on the next pages there. And Gordon, can you just touch on those self-funded options real quick for me?
Yeah, can we go to the exhibit?
Would be page there. Yeah. There you go.
Okay. Wonderful. Thank you. I think, yeah, we've got both options here. On a self-funded basis, basically the benefits to the membership are one and the same. The network of providers is one and the same as in a fully insured environment. The difference is that the city would take on the responsibility to make claim payments, not to the providers, but only to the carriers, to either Anthem or to MetLife. And thus the opportunity exists for a decrease in cost. In a study that we've done on the city over the past, I believe, 7 years for vision, it was determined that the rates were pretty much spot on. Vision is kind of a flat coverage in that it doesn't really have a lot of trend in it. And so the claim projections were pretty much hit. But the one component that is always included in fully insured and in self-funded rates as well is margin. Margin is a basically, if you will, a claim reserve to make sure that the carrier collects enough money to pay all claims. And in the event of adverse claim activity, still can have that covered. In the fully insured environment, at the end of the year, if those margin dollars are not used, they've been paid within the premium rates, they remain with the carriers. On a self-funded basis, the opportunity exists for margin. First of all, it would not be remitted to the carrier only if needed in claim cost, but the margin component would stay with the city. In the vision program alone over the last 7 years, and that does include the 2020 COVID year where utilization was substantially lower, but it's over a $2 million savings that the city would have realized in its vision program. We estimate going forward a little over $200,000 per year would be saved by self-funding, simply because we don't believe that the margin will necessarily be realized in claims because of the predictability of the claim cost. So with that being said, that kind of gives you a background on self-funding and why it's one of the areas that we think the city should consider going to. In the first proposal, you can see that the administrative cost proposed under Anthem is 59 cents. Now they do a estimate for claim cost as well too. That gets you to $8.81 in total for a decrease of -4%. We don't need to follow their estimated claim cost. That is usually an independent study that we as your consultant would do for you to have you reserve the appropriate amount of monies. As a matter of fact, I can tell you that in the first year of self-funding, we typically recommend that current rates are maintained, and but yet what you would be remitting is only the administration and then the actual claim cost to the carriers. What that does, so for instance, under this either whether it's Anthem or MetLife, if the self-funded premium were also $9.17, what it would mean is that 59 cents, the admin fee per employee per month, that cost would be remitted on a monthly basis to Anthem, and then requests for claim payment would also be made by Anthem on a regular basis. Under MetLife, we have the same arrangement. Their admin cost is 45 cents per employee per month, with $8.05 for estimated claim cost, for a total of $8.50. I think the important thing here is to really, as I mentioned earlier, we would recommend if you were to self-fund, keep the rate at $9.17. But the difference between the two proposals is really in the admin fee. On the one, you're paying 59 cents per employee per month. In the other, you're paying 45 cents per employee per month. And if we changed to the option 2 for either Anthem or MetLife, the only difference we see is that the claim cost goes up. Here you can see projected at $8.87, the claim cost under Anthem, and $8.63 under MetLife, getting a total of $9.46 versus $9.08. And so either way, I think one of the nice things here is the opportunity under self-funding. Once you build sufficient margin and so forth within and is held by the city, oftentimes you can find that you can afford yourself these kind of option 2 plan design adjustments without even necessarily changing the rates. So the $175 contact lens allowance, for instance.
So both the fully insured and self-funded components were taken into account as we were evaluating the proposals. There was also some, we call them quality areas that we looked at that we talk about as far as the self-funding arrangement is concerned. The number of things that the carrier will take care of for you. The burden is not 100% on you. It's kind of shared. And Anthem's proposal provided an overall better position, even though it's slightly higher than MetLife's. It would not pose undue administrative burden on city staff, but still provides you with the opportunity to reserve, bring down rates, and have greater control over your plan design. So all things being equal, we evaluated the financials, but the other piece of this puzzle is also the geo access and the provider network match and disruption. And we can't talk too terribly much about Anthem's provider match and geo access. They did redact a number of items in their proposal, but suffice it to say that Anthem does lease a network from IMED. So that was a very big bonus. They leased the Insight network from IMED. So a transition from IMED to Anthem would mean that your provider match is almost identical. that fluctuates with contracting over time based on a point in time. But the impact to membership would be minimal. The exact numbers, obviously, we can't talk about right now, but that was reviewed as well as the MetLife provider match, which was substantially lower. It came in at about 62% provider match. Now MetLife did indicate that they would recruit on behalf of the city to increase that number. However, initially out the gate, there would be about 38% disruption on that front. So that being said, the disruption with MetLife, the financials, and also to the stronger position for potential to self-fund, that all went into our evaluation and looking at a strategic kind of long-term plan. We recommended that Anthem be the provider that is looked at for the next contract year. Are there any questions that I can answer about disruption, financials, match to current? The other note I did want to make is that with the Anthem program, they will be able to match that plus provider program that the city currently has that was put in last July.
A quick question.
Yeah.
Why did our current vendor submit a bid?
They did not submit a bid in time. I don't know how much of the details that we can kind of go into, but they did not make the deadline.
They submitted, but it wasn't.
It was not a technical error. I do know that the integrity of the RFP was maintained. It just did not get in by the stated deadline in the RFP.
When you talk about provider match, are you talking about the providers that are actually used by everyone or just providers that they have available?
Provider matches match to current providers that are used.
So the question of disruption, you said minimum disruption. I don't know in detail what that means here, but what about Kaiser members who are not Anthem members? They have their own plans, and how do they apply or integrate their program into Anthem without disruption?
Have disruption. So Kaiser members actually can utilize the standalone program themselves through IMED currently, and that would not change. They can get an exam through this standalone program, and they can also have their exam through Kaiser as well. It's all in how they want to purchase or seek their coverage.
So Anthem is now the IMED, if you will. I have a Kaiser code number, whatever my employee number. When I go in, I have a phone number. None of that changes. Not a different phone number. Someone picks up, hey, welcome to Anthem now.
Well, there should be a different phone number. They will get a new ID card, if you will. It will be a new program, but the providers that they're currently seeing would be the same providers that they see today. And the process should be the same. So.
Okay.
So our current Kaiser employees don't use Kaiser as their eye provider.
Most
do they?
don't. Well, they believe there's a basic exam that's built into your plan and they can use that. But I would imagine most, and based on the utilization that we've seen in our service provider presentation, you have good, healthy utilization on the IMED program with respect to exams and materials.
Okay, even with Kaiser members.
Correct.
And so this would just change, and it doesn't have a different effect on current Anthem members. We're not going to, or they're not going to get some sort of easier service, some sort of easier time.
There is a service that's being proposed. It's called the Whole Health service, where they're going to kind of connect the vision care in with your medical care and be able to identify much quicker, diabetes and some of those preventative health indicators that come with getting a vision exam. So there is a little bit of an enhancement there. In fact, Anthem does, they provide that across several lines of business, but this would just add vision to that. So there is an enhancement that's there, kind of integrating that together. They would still be seeing the same IMED network providers, but they would be able to have that benefit.
Plus provider, IMED 360 plan. That's an enhancement. That's additional, optional.
That would be maintained. Yeah. In your plus providers, just a note, roughly 50% of your utilized providers are plus providers currently. So that's really good that your members are able to have the added benefit of an eliminated copay at the time of service, as well as a little higher frame allowance and various other things. So about 50% of the providers that are utilized today currently are plus providers, and they would be able to continue to see those.
Yes,
So this is the cost of the plan, in the same way that IMED was, because before IMED, you had a choice of if you're gonna take insurance or not. This is similar in that the city's just gonna provide it to everyone and you're just a member automatically.
Correct. It would still be considered standalone, even though you would have that added enhancement of the whole health component.
So what kind of, actually, if you have them, could you review what is the utilization of the current IMED, and for Dana's question? My real question is around kind of education to the members, because you can use Kaiser members, for example, can go to Kaiser for vision care, and then they realize that it's not actually part of it,
Yeah.
so it's extremely expensive.
Right.
So what's the utilization, or do we have that?
I actually don't have that with
Okay.
me right now. And some of the utilization, we did provide, and I can pull up. I don't know, Melissa, if you want to pull up the service provider presentation, because we do go over that annually. What Kaiser members are doing versus the IMED program. So hopefully she'll can pull that up, but yeah, that is a component. Education is key. It is not the same type of a program. So you're definitely going to want to make sure we're touching on that. And if you do transition over to Anthem in particular, that's another added layer of component, another opportunity to educate your members about the difference between the benefits of your medical program versus the IMED or Anthem Insight benefits. And even to the plus providers, being able to seek those providers as somebody who wears glasses, higher frame allowances, kind of gold.
So my question is to that point in terms of in the transition, what kind of education do we conduct to make sure the members are aware?
There would be a whole implementation and transition program. Anthem would help the city and assist the city with that, as well as the city staff. There would be, milestones and timelines that we would need to be communication pieces as part of open enrollment. Now, this program is for 1/1/2024. So we would be gearing that up as part of the open enrollment education and all of those activities. So it would be part of that process.
We say April 1?
1/1/2024.
Okay.
Sorry.
Yeah.
Oh my goodness, no,
Oh.
we missed the boat.
I was like, 4/1.
We just,
I know.
yeah.
No, I
My brain did-
I'll just add, so we did when we built up. We unbundled this package, we did have an uphill battle on trying to educate the difference. We created flyers that make the difference between using your optometry services versus ophthalmology services. It's still a hard message to be able to communicate. Both proposals identified the continuance of pop-up clinics, so we'll be able to utilize those and use those as an education piece on top of both enrollment activities and other pieces throughout the program. But it will always be a difficult education piece since we've unbundled the product between those two, ophthalmology and optometry.
And further, it's going to be a little more confusing because we are, recommending a selection of a vendor that provides the medical for, some population of the city. So it almost seems as though, if you have Anthem, this is your new eye people. And if you have Kaiser has eye. And so we have to make sure that they understand that Anthem just happens to be the vendor that is going to replace IMED.
Right.
And I think the branding piece goes into the education, Anthem's Blue View versus Anthem, right?
For sure.
I have a
Question. It looks like at least half of the difference between the two estimated changes in the premium rate per month are attributable to the estimated claims. And I was surprised to see such a large disparity between what Anthem quoted and MetLife quoted for the estimated claims per member per month, given the fact the plans are identical. Is that typical? And how would that impact the city's decision if it should decide to be self-funded potentially?
So, Borden, you can chime in here, or even, James, our actuary, is here. But if you self-fund your plan, they provided estimated claims costs for purposes of analysis. But if you self-fund your plan, we would actually be doing an analysis and a workup every year, looking at our reserves, looking at the experience, looking at the claims, and providing estimates to you and options to you for rates on an annual basis. And that's a process, it almost like similar to a renewal that we would engage in with you on the committee in order to identify whether or not, if you're reserving and you don't want your reserves to get too high, so perhaps maybe we look at a benefit adjustment and enhance a benefit. If reserves are getting low, then maybe it warrants an increase based on what the claims look like when they're coming in. So that's a process that we as your consultant would assist with. The estimates that came in from the carriers were done by the carriers. And so it's two different underwriters. It could be two different methodologies, philosophies, as far as how much, what the trend would be and things like that. Borden, do you want to add to that at all? So it's not out of the realm of.
But Keenan hasn't done that and doesn't have what it would be. It's estimated per member claims per member per month.
Right. So we
And
actually do have a workup, a projection included in the packet for you to review, and our underwriting helped with that. But Borden, do you want to add to that real quick?
Yeah, like I mentioned, when we were going over our financials, we would encourage to keep the current rate in place, just as it would be for the option one under Anthem as well too, is to keep the current rate in place. We believe the underwriting does show that it supports the current rates, but not only that too, it allows us to build the required margin to make sure that we are hitting our targets on time and so forth. If we were to do the rate reduction as the carriers indicate we can, first of all, there's no margin built in to those rates. So we run the risk of not having money in case claims come in higher. So from that perspective alone, we really encourage a more conservative approach. And like Megan said, we did do the underwriting as well too, and that supports that fact as well.
So our projections, based on, James, I don't know if you want to come over here and speak to this. Our projections for claims costs, just on the Anthem proposal matched to current, are $7.98 PEPM. Yeah. So that we took a look at the claims and the experience, and we made a projection as well based on what we see happening out there in the market. And, some underwriters and some rate developments are a little more aggressive, some are more conservative. It's obviously it's that crystal ball. You're taking a look at what happened, looking at current state, and then trying to project for the future. And so again, some folks are going to be a little more conservative or aggressive, depending on their style of underwriting. We tend to fall right in the middle. We don't want to be overly aggressive. We don't want to be overly conservative. We want to hit that sweet spot. And so that's what we strive to achieve. And James, do you want to add anything?
No.
I have a question.
Yes.
So 5 of my locals have IMED supplements. One hasn't. So what will happen with that if we decide to go with Anthem? Do we have to, do the locals individually have to go for the supplement plan with Anthem, or do they stay with IMED, or what?
I don't believe they're tied in any way to the supplemental program.
No, so it would fall under the dual benefit concern or dual benefit use issue. So it would all depend on if the other plan allows dual benefit and how the services are rendered. That might be a thing. I'm under second question.
All right, Thank you so much.
Can I ask one more question if I might? In reading the documents provided, it looks like IMED was the provider that helped meet the deadline, it's our proposal.
Right.
Does that mean that the city is compelled to change provider?
As part of the process, it means they did not have a proposal that we could evaluate. And Paul, I don't know if you want to speak more to that.
Yeah, so under our RFP rules, and how we regulate, we can only consider the proposals that were received. So our options on the table are only ones received by the deadline. We wouldn't be able to consider anything else held outside.
So renewing with IMED is not an option at this point.
Correct. Oh, so I would say just for time, we do have a lot of items on the agenda. Keenan was a consultant on this, their advisory staff is the one that actually rated for the qualifying score, so I want to give time to be able to wrap their rest of the presentation. For like 5 minutes. And then maybe we can follow up within the other.
Good morning. If I can direct your attention back to section E of the report, it will list or summarize the final scores that the review committee provided for both proposers, and you'll also see Keenan's final scores there as well. Overall, what Keenan had mentioned, there was a big difference in the access / continuity of care, specifically in the provider network and disruption sections, as well as the financial cost and benefit design. We've already went through those details. And as you can see from the final scores, Anthem had a slight advantage towards MetLife in the overall scoring. But I did want to point out some considerations that are in the body of the paragraph. Our recommendation is to tentatively select Anthem under the stipulations that negotiations on certain sections that are listed in the RFP are agreed to in the deadline that we provide is in the next 45 days. Should these negotiations be unsuccessful, then we recommend that we move forward with negotiations with MetLife for the discussions and the reasons that we had listed. Therefore, it is our recommendation that the JLMBC should recommend to the general manager of the personnel department that Anthem Blue Cross be tentatively selected as the provider of the LAO program's vision plan for a 3-year contract beginning January 1st, 2024 through December 31st, 2026, with an option for up to 2 additional 1-year terms pending successful negotiations by the personnel department with Anthem Blue Cross for at minimum contract requirements, prices, sus premiums, and service level agreement.
And what?
Service level agreement.
Before we move to recommendation, just a quick follow back. You said there's minimum disruption. It seemed like in the conversation, most of those concerns we have been mitigated in some form or fashion. Did we miss something? What would, and is there a number, 1% disruption you project, or what do you see as a potential disruption if any?
Trying to be very careful because it was redacted in the proposal. It was greater, the network match was greater than 95%. So, and I can't give you a fine number, but it was a little higher than that because it was redacted. So, as compared to MetLife at 62%, greater than 95% provider matches is very good.
And the recommendation is only for Anthem. You mentioned a secondary, but if Anthem doesn't meet your negotiation, that's not part of this recommendation to then negotiate with MetLife. Okay. Huh?
Why not negotiate with them both at once?
So our RFP rules say that we can only negotiate with the selected vendor. So we can only do the award negotiations with whoever's, and others who were recommending the provision that makes the ground on negotiating price, negotiating performance guarantees and other contracts.
And that's fine, but my point is that there is no recommendation here that says, if that doesn't work, we go to MetLife. That'd be something you bring back to committee because there may be other concerns.
Well,
So the recommendation is only for Anthem right now.
correct.
Correct. Okay. It's not an automatic, let's go to MetLife afterwards. You'd come back here and we have that discussion.
We would update the committee, correct?
Okay.
But
That's-
under
that's
the
my-
rules of the RFP, that's how.
No, I got it. It's not an automatic. I just want to be clear. That's not what this is.
Understood.
All right. Any other questions from committee members?
Quick question, if you don't have successful negotiation with either vendor, what is the plan?
So, I can speak to that. So the city always reserves the right to cancel the RFP or find that something is unsuccessful and be able to go back to, I'll wait, we'll extend the current contract. That would be option 3 or D, I'm not sure. I'm the number we're on there. Yeah. That would be the final option, assuming that the current contractor is going to be. At that time.
Is there a motion to accept the committee's recommendation?
I move.
Been moved in second. We'll take roll call.
So if I could. Real quick. So let's do in the same order. We'll start with you, Dave. Dave, your vote.
Aye.
Dave votes aye. Marlene, your vote.
Aye.
Marlene votes aye. Chad, your vote.
Aye.
Chad votes aye. Gary, your vote.
Aye.
Gary votes aye. Dana, your vote.
Aye.
Dana votes aye. Tony, your vote.
Aye.
Tony votes aye. Matt Sable, your vote.
Aye.
Matt votes aye. And Petty Santos, your vote.
Aye.
Petty votes aye. It's unanimous. The motion passes.
Okay, thank you.
Mr. Chair, I need to excuse myself, so Paul Gerard will be taking my spot.
Do we have to take?
Sorry?
I'm just kidding. Yes.
Yeah.
Thank you. Yeah. Agenda item number 5, committee report 23-16, wellness third-party administrator request for proposal.
Thank you. And so for this one, Daniel will be starting us off remotely.
Great.
Daniel?
Good morning, everyone. Daniel Powell from the Personnel Department, Employee Benefits Division. So I'm going to kick us off with some background about this program. The Live Well program was launched in 2017 and was solely consisted of educational materials to promote existing wellness services already provided by the city's contracted medical providers, Anthem and Kaiser. Around this period, the city hired a full-time Fuse Corps fellow who helped establish a direction for the wellness program and provided guidance in a lot of areas, including help with identifying contractual support. So working with the Fuse Corps fellow, the Live Well program defined its branding and marketing strategies and used activities and educational events to reach members. Later in 2017, the city released an RFP for a third-party administrator to provide a platform and related services to support wellness efforts. The RFP sought a TPA that could immediately support the program's existing efforts with the intention of eventually expanding to include more services. In May 2018, Limeade was selected as the winning bidder. That firm scored highest across all the RFP rating areas, particularly in the areas of website support and content. And they offered a robust proprietary wellness-focused platform that was both engaging and accessible. And subsequently, after selecting Limeade, the JLMBC had contemplated additional ways to enhance member engagement and chronic care management. Specifically, the JLMBC had an interest in a model where Limeade could provide more finely tailored health-specific services to members. But there was an issue that Limeade couldn't receive personal health information from LAWell providers and would need to rely on individual members either providing HIPAA consent or directly inputting their medical data into Limeade's platform. The effort didn't move forward to these concerns about member privacy and the concern that asking employees to provide health information directly to Limeade would be overly burdensome for the benefit provided. When Limeade was implemented, its platform was promoted by way of several communication channels, citywide emails, mailings, new employee orientations, on-site wellness events. And while the total number of eligible employees varies each month, it's generally between 25 and 26,000. And during the term of Limeade's contract, approximately 4,400 employees are registered on the platform, with about 20% of those on any given month using the platform. So while there's a strong number of employees who diligently take part on the platform and participate in the activities, um, zooming out in the big picture, the resources somewhat underutilized by the overall eligible workforce. And further exacerbating this concern was the fact that the Live Well program had to discontinue on-site activities during the pandemic, meaning that just the online platform was the primary mode of engagement. And as we know, through the course of the pandemic, a large number of employees have transitioned to a work schedule that involves either working remotely full-time or on a hybrid basis, meaning that the program needs to consider additional ways to engage with employees. An additional challenge that we know in the report is it's difficult to measure how the platform has positively impacted members' health outcomes. The Limeade platform can report on how many members participated in wellness activities, but there isn't a reliable or comprehensive way to measure how those activities improve health outcomes. So with this year's RFP process can give us an opportunity to build on the past successes of the program and expand in ways that account for the program's current shortcomings. And then the next section here is going to be taken by Siegel.
Thank you, Daniel. Steve Murphy with Siegel, and I'm joined by Stacey Rossi, who's one of our clinical consultants. Thank you for having us this morning. With regard to the request for information, so one was issued in January of 2023, and our intent was to gain insight into perhaps changes in the market environment, what new vendors may have arrived, or what kind of new services and resources are there. Because to Daniel's point, I think one of the big questions that we have going into this are how to, again, build on what's there, but also try to understand what obstacles are currently in place. So as an example, gathering data from members so that the vendor can contact them and engage them. I'm going to steal from Anthem's presentation in a few minutes, so I apologize for that right now, but using the Anthem data, currently a third of the covered population has a chronic condition, hypertension, diabetes, low back pain, etc. So the idea is, how do we get more engaged with those individuals to help them with those conditions, and how do we prevent people from getting to that stage where it becomes a chronic condition? So that's the overall challenge. The RFI, we got 9 responses back, which was a good indication of, I think, interest in working with the city. But we did pose a number of questions to gauge if they could work with the current circumstances that exist. So for instance, how would they perform without eligibility or claims data feed? So again, in the perfect world, you would know that someone has taking diabetes medication, so you could do outreach. That doesn't exist currently. So we need to know if a new partner is going to be put in place or if Limeade is going to be retained. Can they work around that obstacle to get us to a point where we're actually seeing positive progress in terms of managing and reducing the impact of chronic conditions? There also is a either low or no incentive process that exists in other wellness programs. Members are kind of doing activities to gain cash back or significant cash back. And that's not been the philosophy of the city in the past for a number of reasons. So again, we want to know if those vendors have experience in working in that environment so that they can engage members without knowing that those cash incentives exist. So through that process, we'll kind of work through that. But overall, we're kind of pleased with the initial reaction from the marketplace and look forward to the RFP. So I'll turn it back to Daniel. Oh, that's Paul.
And actually it's me. In short, we think that the wellness program can do a lot more than what it's currently doing. And so the objective is to find a vendor that in the widest way possible that can hit a lot of marks. So we're proposing this RFP in a larger setting, asking lots of bold questions to try to find that happy mix between somebody who can still do the services that we're asking for, but also hit a larger range and be able to make the connections that Steve just pointed out, and be able to actually use health data to actually move towards a measuring metric that we can see that people's health is improving. I'm not sure if there's anything else Siegel or Daniel want to add into that. But if not, we can go quickly into the overall RFP format. We are copying what we've done for the prior RFPs. The only difference is that we cannot exclude this from the business inclusion program for this particular vendor, because there will be subcontracting opportunities. We can see them already. So that will be a component in this request. We are going to be asking a very wide range of questions in the questionnaire. A draft is attached in attachment C, but those are just draft categories right now. We still are forming new questions or trying to make sure we're asking all the questions we possibly can in those categories to be able to build the net that we're looking for, with the optimal component being us finding vendors who can actually contract and work with our medical providers and other providers currently. And then we have a draft schedule that we're going to be asking, that we're going to be working on to try to get this developed, issued, and then selected in time for transition with our existing vendor, should that be the case, if we have a new vendor, by April of next year. So it's a very short timeline. Is there anything Siegel wants to add in, or Daniel? And then there's also a pledge that we're going to be asking JLBC members to complete, but it's optional for JLBC members. It's mandatory for staff involved in this project to make sure there's no conflict of interest in any selected vendor during the process. So the motion on the table is to, or the recommendation on the table, excuse me, is to approve the draft RFP and concept and the issuance of the pledge. Any questions?
Hearing none. Is there a motion? So moved. And we're looking for a second.
Second.
Move the second, and we can call roll for approval.
Thank you. So we'll go in the same order. So Dave Sanders, your vote.
Aye.
Dave votes aye. Marlene, your vote. Marlene votes aye. Chad, your vote.
Aye.
Chad votes aye. Gary, your vote.
Aye.
Gary votes aye. Dana, your vote.
Aye.
Dana votes aye. Tony, your vote.
Aye.
Tony votes aye. Paul Gerard, your vote.
Aye.
Paul votes aye. And Petty Santos, your vote.
Aye.
Petty votes aye. It's unanimous. The motion passes. That's our last action item.
Thank you, sir.
But yeah, for the record, I'm going to excuse myself. I will not have my alternate here, but I believe there's no need for any further vote.
Correct.
Thank you.
Okay. Agenda item number 6, benefit provider presentation from Anthem. Good morning.
Good morning. Thank you for having us. I'm Melissa from Keenan, and we'll be doing a brief overview, but Anthem will do a deep dive on utilization over the 2020 plan year. To start out, we'll look at current demographic. Next slide. So we'll see the plan membership, is in trend with what we were seeing with the Kaiser presentation previously. We did recently have the separation incentive program, so there were a decline in enrollments. We do see consistency in the membership demographic, very similar, again, what we've seen with the Kaiser program. Looking at membership health and wellness, we do see a decrease in healthy membership with increases at membership at risk and chronic conditions. And we do see right now that chronic conditions drive 59% of total plan spend, with 8% of membership with hypertension, low back pain, diabetes among that membership. We do see good utilization on the program, higher than the Southern California benchmark at 86%, the city at that 93%. We do see an upswing post-COVID with the preventative care and then screenings, with a slight decline on the cervical screenings. Next slide. Looking at utilization is up above pre-pandemic levels. Key drivers are outpatient utilization. There has been increases in emergency department visits, but lower cost per visit, but still the number of visits are driving up costs. Other outpatient drivers are your chronic kidney disease, chemotherapy, and breast cancer. There's also been increases in professional setting with therapeutic injections, increase in the number of high cost claims. 0.2% of members account for 22.1% of total plan cost. Looking at those top 5 health condition spend categories listed below: cancer, behavioral health, health status, musculoskeletal conditions, and genital. And that is our introduction, and Anthem will do a deeper dive into that utilization. Thank you.
Good morning. My name is Kristen Nelms. I'm a director of our strategic accounts here at Anthem Blue Cross. And we're so happy to be back in person after 3 years with all of you. So thank you for your time this morning. We brought with us our clinical team on our medical and our pharmacy benefits to share with you some insights as to what we're seeing with your current claim cost. So I will turn it over to Dr. David Pryor, who is our medical director, as well as Gilbert Soto, who is our client analytics member of our team. Once they go through the medical portion, then we'll turn over to our pharmacy team so they can dive into those details as well. So with that, I will turn to the team. Thank you.
These gentlemen are doctors.
Yes.
Good morning. Good morning.
Maybe we'll start on the next slide, just to kind of level set on the parameters that we're using. So we are looking at paid data January through December 2022. When we refer to high cost claims, we're looking at claims 250,000 and above. So keep that in mind with any references to high cost claims. Okay, and with that, we'll go to the next slide. And so what we did with the data is we summarized it into two parts, financial and clinical. And the question that we're asking on the financial is what's driving trend? So we see that overall per member per month paid amount was 280. That's an increase of 14% from the prior year. When we look at that compared to our benchmark, it is above our benchmark, which is 8.5. Now, some of the factors that are impacting trend are that we did see a decrease in your membership, while overall risk score did increase. So we see that risk score jumped up 10%. Prior to 2022, your risk score had remained flat, but we did see that going up. We did see costs going up. And as it was mentioned earlier, we did see a big increase in your overall utilization. Utilization went up by 16%, and it's even above where it was pre-COVID. So around 2019, we did see a decrease because of COVID in 2020, then a slight increase in 2021, and then now what we're seeing is an even greater increase in 2022. And then another thing to point out is to just looking at your high cost claims, again, claims over 250,000, just the medical portion went up by 48% compared to the last year. So we did see a big impact in high cost claims. Moving on from just your trend, you start to look at where are we seeing the cost increase. And two of the settings that we saw this were within the outpatient setting and professional setting. And within the outpatient setting, what was driving that cost was a lot of procedures related to cancer. So chemotherapy is driving some of those outpatient costs. Emergency department also saw an increase in utilization, as was mentioned before. And although it is a 30% increase from last year did have the lowest amount of utilization post-COVID. So that 30% increase is looking at a year where it was pretty low in 2021. Looking at your professional setting, which is typically your lower cost setting, what jumped out to us was that your therapeutic injections was driving your professional setting. So that's basically your medical pharmacy in the professional setting. So getting some sort of pharmacy treated in the doctor's office was driving this professional setting here. So what we saw was disease of the blood, so hemophilia, that was a high cost claim within the professional setting, and an overactive thyroid. So those two procedures were really pushing that overall cost, excuse me, in the professional setting. Then when we look at overall utilization, as we had mentioned, there was an increase in utilization overall, but we did see an increase in well visits and compliance rates for cancer screening. So that's good news. And it was above our book of business. Then touching on emergency department, as I said, we did have an increase in utilization. We did see that potentially avoidable ER visits accounted for 45% of your visits, which is roughly about 1.2 million in potentially avoidable spend. And then rounding off of this financial slide here, we see that high cost claims jumped from 29 members to 42 in 2022. Again, these are claims over 250,000. And we did see that there were 3 members with claims over $1 million compared to just 2 in the prior.
Yeah, and so I just, again, Dr. David Pryor here, just to summarize and add to what Gilbert has said, I mean, what we just described is not unique. We are certainly seeing this kind of rebound coming off of COVID, where 2019 was the kind of the pre-COVID era, and almost all the large employers, after 2020, it was a low year of utilization and expenditure. 2021, it's crept up, and 2022. So it certainly is returning. And really kind of exceeding a little bit of the pre-pandemic levels. We do expect hopefully that will level off, but there was this phenomenon of people not getting care right? And then now the rebound has come back as we start to return. So just wanted to put that in some context as well.
Thanks. And then we can move on to the next slide, please. So here we're looking at clinical findings, and the question we're asking is what health conditions are impacting the population? So the top 3 conditions by spend were cancer, behavioral health, and musculoskeletal. So within cancer, we're seeing about 520 members, accounting for about 8.6 million in spend in cancer. A lot of that's driven mostly by chemotherapy and breast cancer. When we look at behavioral health, we do see an increase overall in utilization, which is typical of what we're seeing with most groups. But when we look at the top 3 spends within behavioral health, we see depression, development disorder, and alcohol disorder as the top 3 by spend. And just to give a little more detail on the development disorder, that is driving some of the costs that we see within the children, so it's related to autism. And then when we look at musculoskeletal, we do see about 27% of your members have MSK condition, and it's counting about 7% of your total spend. We did see that MSK surgeries increased from 49% to 52%, which is higher than our book of business, which is around 50%. And then the top rising chronic condition within MSK was, we did see that low back pain was the number 1. And we did see that spouses had a higher prevalence of low back pain. Then rounding off this slide here, just some key notable findings within the data, looking outside of just total spend, is we look at chronic conditions by prevalence. We did see hypertension, low back, and diabetes as your top chronic conditions by prevalence. We also saw that about 6% of members had 2 or more chronic conditions, which is slightly above our benchmark. Our benchmark is at 5%. And then kind of looking at who's driving costs or who has like the higher prevalence, you see that employees accounted for the highest prevalence of both hypertension and diabetes. And then just looking at lifestyle conditions of the top 4 by prevalence, we did note that obesity and lack of physical activity were the main lifestyle behaviors that were directly affecting those conditions. Positive.
Yeah, no, no, that's great. You want me to move on to some of the thoughts or areas of focus?
You said the increase was for the employee, that mean not their family members, what you meant by that?
Oh, that meant the prevalence. So there was higher numbers of employees that have hypertension and diabetes compared to spouses and children.
I have a question on the behavioral health section. I mean, there's no surgeries involved. There's no, like, where is what is the population?
Yeah, good question. So with behavioral health, we did split in the data, kind of the settings of what we're seeing it. When it comes to children, professional setting is where most of that cost is. So for children, we saw like eating disorder, autism as those high drivers within the professional setting. So it may not be high in cost, but there's a lot of volume there as well.
Yeah, and I think I would add just in, the culture that we have, the great thing that, the stigma of behavioral health and behavioral health treatment has gone down quite a bit, right? People are more open about it. So that's a good thing. So with that lack of a stigma as much, more utilization. So you're right. And there is, as you said, sometimes inpatient stays for eating disorders and things get very serious, but a lot of it is just more awareness, more volume, and a good thing, more people kind of reaching out. So I always look at behavioral health utilization as, perhaps it's a good spend, right? You want to get people get treatment, talk about it so that doesn't impact their physical health.
Could you go back a page? It says for the emergency department, potentially avoidable emergency.
Yeah.
So how do we make it so it's avoided?
Yeah, let me talk about that for a minute. When you talk about avoidable ER visits, that's when somebody goes to the emergency room and after they're treated, they're triaged, it comes out that maybe they had a urinary tract infection, or maybe they had just an upper respiratory, a bronchitis. And you say, well, that's something that certainly could have just been treated at their doctor's office or in urgent care. The tricky thing there is that, sometimes if somebody's coming in and let's even say a headache, they say, gosh, I have the worst headache of my life. You never know. Could that be a bleed, right? A hemorrhage? Or could it just be a bad migraine headache? And you never know until you go through, you get them a CT scan, you go through and you work them up. And then at the end, if it comes back. So that diagnosis of headache at the end, you could say, well, that could have been avoidable. You could have gone to urgent care or your doctor. So it's always a little tricky because sometimes for that person, whatever symptoms they're feeling, they don't know for sure. Does that help out? But we do characterize it as avoidable at the very end when you're leaving that emergency room. If it's just, gosh, just a urinary tract infection, we say that could have been avoided. But sometimes from the patient's perspective, their symptoms may be, stronger when they first come. Does that help?
Yes, thank you.
I'm curious, do you keep statistics on whether or not emergency room visits had patients have access to urgent care at that same time, or is that baked into the number? I mean,
Yeah, we do look at all of that. And I'll tell you real quickly, the trend in emergency department usage for years, it had actually been going down. People were really getting the message, go to urgent care, don't go to the emergency department, and obviously use telehealth. So that message had been really resonating, and we saw across the board that the ER visits were going down. Interestingly, though, this last year, again, coming out of COVID, we've seen these ER visits going up, and we're still trying to get our arms around that because you would think with telehealth now being more popular, there's more options. Why would people be going, to the emergency room? So different theories there. One theory is that, gosh, as people come out of the pandemic, more people are on the road. There's more traumatic accidents. People are going skiing. People are getting out and doing things, and they hadn't done it in a couple of years. So sometimes they're actually going to the emergency department appropriately, right? Because they're having these injuries and things. So it's something that we're tracking very closely, but it's not unique to you all. It's something we've seen with other employers.
I think one important thing is make sure that people have acceptability to the doctor.
Yes.
In an emergency or not, if they get to the doctor, they're fine. If they have more options for urgent care, more locations where people can get it. Because they know if they go to emergency, the minimum is probably 6 hours. Having availability and many options out there to get to from the location.
Exactly. But just want to mention a couple things just on as we go to maybe even the next slide, areas of focus. Gilbert talked a lot about cancer, behavioral health, and musculoskeletal care. So I just want to mention, if you ask the question, well, what is Anthem doing about it, right? These are obviously the key drivers. So I'll just have a couple observations and then kind of wrap it up. But when you talk about cancer, I always say it's a little bit of a tale of two cities, right? That one thing is that we're in an area here with great world-class institutions, hospitals, right? Cancer care, every year it advances, you get new drugs, new treatments. So that's a good thing, right? It gives people hope that you can cure some of these illnesses. On the other hand, right, cancer care doesn't get cheaper. Every new drug, every new breakthrough, it's not cheaper. Sometimes it costs more. So we are continuing to we have something called our Cancer Care Quality Program. We work very closely with oncologists, making sure that they're following kind of the evidence-based guidelines, right? So they're not kind of, wasting money or doing treatments that aren't effective. So we encourage and incentivize our providers to do that. So that's one thing we do. The other thing we encourage everybody is, gosh, it's getting people back in for those screenings, right? During the pandemic, some people maybe missed some of those screenings. We're trying to encourage people to get in, do those screenings. Colonoscopies now, it used to be age 50, everybody started, now it's age 45. So getting people, in so they can get those screenings, mammographies, that's a big push. The other thing obviously is lifestyle, right? We talked about wellness a minute ago. It all starts with the lifestyle, right? Making sure people aren't smoking, they're eating right. Obesity is tied to a lot of cancers. So as much as we can work on that, that will help. But when people get that diagnosis of cancer, unfortunately, it's not necessarily any cheaper care, right? It's more advanced care. So it's a little balance there. So I hope that gives some insight there, but we continue to work on that quite a bit. Behavioral health, we talked about that. So, some of our recommendations, really promoting the live health online, the telehealth for behavioral health, giving more access to people, which is very important. And so we're really promoting that quite a bit. We have some digital apps and some things people can kind of self-guide themselves to, some treatments and options and how to cope, how to deal with stress. And so we're actually encouraging people to use all of the resources we have around behavioral health. The last part there is musculoskeletal. You heard a lot about the low back pain. Again, that comes back to, gosh, are people stretching? Are they exercising? Are they eating right? Right. That's the foundation for some of that. And then if they do need more, treatment, we have programs that really guide them, and we have guidelines. So we try to make sure that they're not going to like a spinal fusion surgery too soon, right? We're trying to encourage them, do the conservative things first, physical therapy and et cetera. So I hope that gives you some context into some of our activities in those three big areas. Gilbert?
I think that wraps it up on the medical part.
I know we have our pharmacy colleagues here as well. Any other questions on the medical piece before pharmacy comes up? Thank you very much.
Thank you.
Does this stuff include, it includes pharmaceuticals, right? It includes the cost of.
The high cost claims. That's my part.
Hi, everyone. My name is Monique Lowy, and I'm going to be going over your pharmacy performance. So in the 2022 period, we saw an increase in your total overall trend of 18.3%. So I'm looking at that first row. Oh, what was it? 48. Sorry, what can you get this slide? Sorry about that. Okay, so if you're looking at that first row, I just talked about that first quadrant, 18.3% is the overall trend. If you look at that third box, you'll see the specialty trend was at 23.8%. So that's the primary contributing factor to the increasing the overall trend for the pharmacy spend. So the greatest impact to that PMPM increase was really the drug mix. So the drug mix is measuring the changes in therapy and ultimately the changes in the unit cost on a per day basis. So that's what's really driving the overall increase for your specialty and your non-specialty trend. So when you go down to the lower row, you'll see inflammatory conditions. That's your number one indication by plan cost. So that's what's driving the overall trend for the specialty benefit. And in inflammatory conditions, that's where you'll see multiple drugs that fall into that drug class. They treat multiple different types of conditions. Think about things like rheumatoid arthritis, ulcerative colitis, those kinds of conditions, and those are self-injectable drugs that fall into that inflammatory conditions bucket.
Is that one particular drug or multiple drugs?
Multiple drugs can fall in there. Things like Humira, Enbrel, a lot of the drugs that you see on TV would fall.
And in your cost, is there distinction between generic and those brand names, or is that?
Those are mostly going to be brand drugs for sort of that fall into that mix. We'll talk about biosimilars a little bit later on in the presentation, but that's going to be an emerging trend to bring costs down in that bucket. So your primary driver, though, for the increase in total spend is in that middle box. So that's what's called Rukobia. This is for a really ultra rare condition, an immune deficiency disorder. And so this is the number one high cost claimant on the pharmacy and the medical benefit. So just this one drug and utilization of this drug, there were 11 scripts in 2022. That's what's driving, and I should say skewing the overall trend from the prior period because it is so significant. Now, when you look at your total percent of the specialty cost, and you look at that pie graph in the lower right-hand corner, you'll see it's 54.9%. You are tracking along with our peer benchmark when we look at groups across the Anthem health plans in the 14 states. And it's a mix of fully insured and ASO. So you are on track there. And what I'll also say is that when you look at your percent of specialty plan costs from the prior period, it's an increase of 2.3%, just to give you that perspective. But what you should also know is that the specialty pharmacy trend in general is really being driven by 2.6% of your population. So a very small percentage of your population with those complex conditions are what's driving the total spend for pharmacy. Any questions there before we move on? Okay. How are we doing on time? 5 more minutes? Okay. And I'll just say a couple things on the slide and then I'll hand it over to Karina just because I want to make sure that she has enough time to touch base on the indications. But again, looking at your plan cost per member per month, and if you look in that light blue shaded area in the middle of the slide, you'll see that our benchmark is 121.62. So you're tracking right now at 160.71. if we were to adjust that PMPM cost, and remove that high cost claimant, it really would normalize your trend. So again, in the prior period, we only had about 5 scripts that member was utilizing. In the current period, we did see an increase in utilization overall, but we also saw the increase in the dosing regimen as well. So that's part of what, again, what's driving the total pharmacy benefit and trend. And so I'm going to turn it over to Karina to touch upon the clinical highlights. Okay, so we're on slide 51. Hi, my name is Karina. I'm the pharmacist. So I'll be going over the top indications. So we see that the top 2 indications are inflammatory conditions and diabetes, and these are right in line with our benchmark. First, I'll talk about inflammatory conditions. They accounted for 26 million in planned spend. That was 71%. And there was an increase in planned paid PMPM, and that was attributed to increased utilization. So there was 84 more scripts being filled. And also generic fill rate, which is listed there as 21.9. In the prior period went down, and in the current period to 20.1. So that means more costlier drugs like Humira, Stelara, and Enbrel were being used in this period. So, and one thing I want to mention about when I get to the next drug is the biosimilars that have launched in this condition. So diabetes, there was an increase in utilization of 3% in volume of prescriptions, but the drugs being used are costlier. So there was an increase in planned paid PMPM of 13%. Immune deficiency, which is the 3rd category, we usually don't see these in the top 10. And that was attributed to that one drug, the top cost, Ripcovi, and that made up 92% of the planned paid PMPM. And I'll talk about that condition a little bit more. But the next 6 conditions, cancer, HIV, dermatological conditions, asthma, multiple sclerosis, and neuropsychiatric neuro conditions or disorders, those are typically seen in our top 10 conditions. Overall, there was an increase in volume of prescriptions of 5% here, and there was 8% more members utilizing drugs in these categories. I just want to note in the psychiatric neuro conditions, a big chunk of that planned paid PMPM was attributed to a brand drug called Latuda. And that drug just recently launched as generic in February. So we anticipate that that's going to bring down the cost of that cost. Seizures, we don't typically see in the top 10, but here it's ranked 10. And there was an increase of drug mix. Drugs being utilized were more expensive, so that increased the cost. So then I'll go over the top 10 drugs on the next slide. And Ripcovi was the top drug by planned cost and was a significant planned cost of over $2 million. There was 5 prescriptions filled in 21 and 11 prescriptions filled in 2022. And this drug is used for a really rare congenital condition called adenosine dimase.
Yeah, we don't know what that is anyway. but-
Severe, I'm sorry, severe combined immunodeficiency. So what that is they don't have an enzyme. They're not born with an enzyme that's critical for cell function. And this medication is actual enzyme replacement. So it replaces that enzyme, that ADA enzyme. And so it allows the patient to thrive. And they don't have to take all these anti-infective, anti-viral medications because they're not getting as sick and they're not being admitted into the ER as often. 2 other drugs on this list are Stelara and Humira. Those ranked 2nd and 3rd. And those are used for inflammatory conditions like Crohn's disease, ulcerative colitis. And the good news on these is that these are biologic drugs, but the biosimilars, which is like the equivalent of a generic to a brand, are being launched. So the first biosimilar Humira launched in January of this year, and we anticipate 9 more biosimilars for Humira to launch. Also, the first biosimilar Stelara will launch later this year. So we're going to see a significant cost decrease in the inflammatory conditions. And then
What type of decrease do you expect to see on you? What's usually the difference in cost?
what I heard was like 50%, but that's when there's all the biosimilars that launched and then there's more competition. Probably around 10 to 15%, but you know, with within 5 years, I think at 5 years, it'd be more like 50. Oh, yes, Yeah. I'm just talking about. Yeah, correct. Exactly. So there's two other drugs here used for inflammatory conditions, and that's Cosentyx and Enbrel. And then there's a dermatological condition, Dupixent. It's usually seen in the top 10 drugs because it's very expensive. It's used for asthma and atopic dermatitis. Degrees of the oral cancer drug for lung cancer. So we're not seeing that administration cost on the medical side. And lastly, I want to talk about the diabetes drugs, Jardiance, Trulicity, and Ozempic. We're ranked 4th, 5th, and 6th respectively. And Ozempic has been in the news a lot lately because it's been causing a lot of weight loss. So there's been increased demand for this drug. A lot of people want to get this drug prescribed. And I do want to note that all these medications have prior authorization criteria. So a patient needs to have type 2 diabetes and have tried and failed metformin in order to access this drug. So it's not just anyone that wants to lose weight. So, and I'll stop there and see if there's any questions. If not,
But just that overall, so the trends where they're going, and I think you used the word normalizing these trends, I assume the cost is gonna continue to go up. I guess I'd be asking, I'm sure the city's asking, how does that impact the rates and our cost to the city as a whole? I'm guessing that number's going up. It looks like substantial, and I guess those 10 people who are chronic are still gonna be chronic next year.
yeah, so
If they're
that
still
high
around.
cost claimant, for example, with that rare condition, you know, I would say that member is going to continue to be, you know, managed on the pharmacy benefit because the drug therapy is effective in managing that member's condition. But at the same time, there's also other breakthrough therapies that are coming down the pipe and things like gene therapy, right? It's not actual drug therapy, but you're changing the sequence, or I'll let Corinne actually speak to the drug therapy, but that would be something that would be managed on the medical benefit and could potentially manage the member better, or even, you know, provide some kind of cure for the member, which would ultimately mean better at managing costs and possibly a lower rate. But you want to? Yeah, sure. So for Revcovi, there's gene therapy in the pipeline, and it's a one-time treatment at $500,000. And once that's approved, the patient doesn't have to be on a lifetime medication of Revcovi. So overall, and there's medications for hemophilia out there that are being also produced for gene therapy that fall under our medical benefit. So that's the high cost claimant, but then the other piece of that also goes back to the inflammatory conditions. And when you look at the peer rank, you can see it's #1 across the board for all clients of varying types of industries,
I-
varying sizes. So
And that's
the-
my point. Those things are driving the cost, and I'm just trying to figure out how it
Right,
reflects
the-
back here.
the
It's not gonna
bio-
go away.
Right, the biosimilars though, coming down the pipe that are going to be introduced to the formulary, that will also help reduce costs for those members down the road.
But how long would that take for that particular practice?
So that first biosimilar for Humira was just launched earlier this year, so it's still relatively new to the market. At this point, Anthem is going to continue to maintain and keep Humira on the formulary, but we are looking at adding some of those biosimilars. I want to say 2 to 3 of those biosimilar options to the formulary to compete with that Humira drug. So the members will have opportunities to go to those lower cost drugs. And then even through a benefit design change, you could even drive further, you know, utilization to those lower cost options. So those are the biosimilars, and the new ones that are being added to the market are going through our Pharmacy and Therapeutics Committee. And that's how they are assessed to be determined who's going to, you know, which drugs are added to the formulary, which specific options will be part of the benefit. So I want to say that's going to happen later on this year. Karina, do you know the timeline per se? Or? Yeah, eventually we're going to, by next year, we're going to pick a preferred biosimilar within for Humira, and then there's going to be, you know, a decrease in price. But just to give you an example, Remicade has a biosimilar infliximab, and it took 5 years for the price to decrease by 50%.
So we don't anticipate immediate reduction in our costs.
Right.
That's the
Yes.
question right there.
It'll be not for
Right. That's the question.
not for 2020, 30, likely, but potentially in 2024 and down the road is there's more buy-in and uptake of those biosimilars.
Oh, you had a question?
And what's the measurement of the impact of all these resources and efforts on recovery, remission, survival? It's all well and good to talk about our costs, but I want to know what, and full disclosure, I'll say that this question is born directly out of an experience I had this week. I lost a colleague to cancer who had been battling cancer for 3 years. So have you measured that? Are we doing better with all the money and the resources and the energy and the science that we're putting into this?
Yeah, out of the, you said there was 500 members of cancer. Do we know it? Well, like last year, what the number and what the survival rate?
And and also be fair about it. I know that we can't control people, getting cancer or getting diseases. So I get that part, but is there a way of measuring whether or not all these efforts and resources are improving our cause, improving our health?
There are outcomes and adherence. We didn't bring any of that, or that's not included today, but that's certainly something we can follow up with. But going back to our Pharmacy and Therapeutics Committee and how we develop our drug list, those are all being taken into consideration. So, we're always looking at efficacy first, right? What is the potential positive benefit to the member? And then secondarily, we're looking at cost. And that's how we develop our drug list. So for example, even though you see inflammatory conditions, and that's number one, and we talk about Humira and there's a heavy advertising about it. It's on the list though, because it's very effective at providing those outcomes and managing the member and having a better life overall. So that's an example that I would give to that. But I would invite Dr. Pryor to comment on that as well.
Yeah, I just have one comment on that. Excuse me for a second. Mike. Yeah, I mean, that is a great question. And I think oftentimes doctors and oncologists might tell a patient, we have this new medication and it may extend your life for 6 months, but it's not a cure, but this is the next chance, the only thing to do. And I think that's the difficult for that patient and the family to make that decision, that you might take this medication. It may extend your life for 6 months, but you may have X, Y, and Z complications. And so that's that balance. But obviously we live in a place where we don't, ration care, we don't say no, but you're right. It's always tough because sometimes, these drugs and the treatments that come out may not be able to cure or stop a person from dying, and it may extend their life, but it's the quality of life. So it's a great question, but there are some cases in medicine that we, discover something like around hepatitis that is a cure. So you have to keep advancing and having, new treatments available, but it is that balance. So that's a great question. I'm sorry for your loss.
Thank you.
And I think, again, with all of that, it still comes back for this committee, for the city, cost. And that's great. There's going to be something, but there's still a cost, and it is affordable. And I don't know where this trend is going, how affordable it still is.
Comment to that. So a piece of the renewal looks at your overall utilization, your medical and your pharmacy, and then we trend forward what the projections would be for the cost. Historically, we've done a pooling point of medical only. Going forward, effective this coming renewal 24, pharmacy is included with medical and that pooling charge. So these really high cost medications are protected, if you will, from a financial perspective.
2024.
Correct, right. So you'll see that as part of the renewal calculation. And from a member's perspective, they're also protected. Your benefits are very rich. So while the dollars are large and it goes to the claims, there's protections on both sides, for the employer and for the member.
Right, and I would also add, just like Brina mentioned, that, a lot of these drugs that are high cost are specialty drugs that we talk about, but even non-specialty like a diabetes, we have all the clinical programs in place to manage members. So they're going through review and making sure that they meet the clinical criteria to get access to the drug. That way they're just not going and, asking for a recommendation or a prescription from their physician and, going to a higher cost drug when there could be an equivalent that's of equal value, equal clinical outcomes at a lower net cost. there's also other ways to tighten your benefit as well. If you wanted to look at a smaller drug list and really steer members towards those generic options or those lower net cost drugs. We didn't talk about it, but your generic bill rate is a little bit lower. Is a little bit lower than our benchmark. And that's an opportunity where you could, through benefit design, look at steering members towards those lower cost drugs to, manage total cost and total trend a little bit more closely. So that's an option. You don't even have to look at doing it at the, on every plan. You can look at selectively putting that option on certain plans. So there's other ways to look at tightening the benefit if that's something you want to do.
Okay. Anything else?
No, I don't have anything else to add, but thank you so much for having me.
Any questions from the committee? Thank you very much. Appreciate it. We have another presentation, Paul, from this group? Oh, we,
So if we're ready to move to item number 7, I just wanted to give a brief introduction. This is the report back. At the last JLBC meeting, there was a member comment, and there was a request for a report from Anthem on grievance procedures. And so that is item number 7, and I'll turn it over to Kristen.
Okay, thank you. So today we have Natalie Martinez. She's from our Grievance and Appeals Department. She will be online presenting the next report. So Natalie, can you hear us, or I should say?
I
we
can hear you. Good morning. Can you hear me?
Perfect. We can hear you. Very good. All right, I'll turn it to you.
Thank you. Good morning, everyone. Today I will be presenting an overview of GNA, our goals and our purpose, and the scope of what type of appeals we handle, and the 2022 data specific to the city of LA.
is that in the package here?
It should be.
Yeah.
And on the screen.
Yeah, we're on the next slide. This is the right slide. Anthem strives to be a leader in service recovery and meeting the expectations of our members, providers, and our regulators. I'm actually looking at one slide up if you want to go to the slide right before this. There you go. We aim to simplify the GNA process for our members to decrease abrasion and increase satisfaction to ensure we respond timely to our members, providers, and the regulators. To stay compliant, we follow guidelines, policies, and procedures and standards that are set by our state regulators and federal regulators. We also continuously look for ways to improve and drive improvements through root cause analysis. We have a team of process improvement associates who work daily to drive this effort and provide us with feedback on how to reduce avoidable appeals and streamline processes where available. Next slide, please. These are the 4 types of appeals that outline the scope of grievance and appeals, which apply to all commercial medical, behavioral health, and pharmacy. We have our provider appeals and disputes. This is where the provider can appeal on behalf of the member. It could be an admin claim payment dispute. It could be a clinical denial. And again, it's for all commercial, medical, behavioral health, and pharmacy. The next type of case that we have is a quality of service or quality of care grievance. And these are member grievances that are against the provider. It could be a standard member grievance against the plan, or it could be related to a service or care that the member received. And same thing, it applies for all medical, behavioral health, and pharmacy. Our next type of appeal that is handled by our risk and regulatory department, these are standard regulatory complaints that when the member goes through the initial grievance and appeal process and say there happens to be a denial, they want to dispute our denial, they go directly to the Department of Managed Healthcare. They can also go to the Department of Managed Healthcare for any type of appeal where they are requesting an independent medical review. And then they'll also go to the department if they're requesting a review of any type of non-formulary drug. The last type of appeal that we have are our member appeals. These are a review of the adverse denials, or if it's received from the member or authorized rep or provider on behalf of our member for any type of administrative appeal request, if it is relating to a denial of a claim or a benefit payment on how a claim was processed, or our clinical claims. And this also, again, applies to all our commercial, medical, behavioral health, and pharmacy claims. Next slide, please. On this slide, we'll go over the data. This is the case type overview for calendar year 2022. And we've broken it out by post-service, pre-service, and prescription. For 2022, there was a total of 240 appeals or grievances. There were 22 that were post-service, 4 were overturned, and 18 were upheld. We had a total of 218 pre-service appeals, 39 were overturned, and 179 were upheld. And then we had a total of 68 prescription appeals that came in. 19 were overturned, and 49 were upheld. Next slide, please. On this slide, I'm giving you case examples so you can see the different types of appeals that I outlined in our GNA scope of what that might look like coming from each type of claim or type of appeal. So the first one is a provider appeals dispute. It was a pre-service appeal submitted by the provider on behalf of the member for quantity limit on prescription drug. This was an uphold as the provider was requesting a quantity over the limit and the medical criteria was not met based on medical policy guidelines. The next example I've provided is a quality of service, quality of care. This was a post-service appeal submitted by the member who filed a complaint against the physician for lack of care and not treating specified conditions. This appeal was resolved. The complaint was reviewed with the provider and it was addressed. The next example is a member appeal. This was a post-service appeal submitted by the member who was appealing a claim payment. This was an uphold. The reason it was an uphold was because the medical group paid the claim at the maximum allowed amount. The emergency physician provider was prohibited from balance billing the member. And when our emergency providers balance bill the member, there's a letter that we actually send out to the provider to let them know that they cannot balance bill the member. So sometimes when members see an uphold, they think that we're denying the claim. We didn't deny the claim. There was just no additional monies that were allowed on the claim because the emergency room rendering physician was not allowed to bill the member for additional monies. So we do reach out to our providers in this instance, and we do send them a letter to let them know that they are not allowed to balance bill. The last example I have here is a member appeal. This was a clinical appeal, a pre-service clinical appeal submitted by the member for an injectable medication. This was an uphold as the medical criteria was not met for the injectable drug, and these are reviewed by our clinical teams. So these are the 4 examples that I've provided. These are appeals that came through for the city of LA. Just to give you an overview of the different case types, we do see a lot of provider appeal disputes. There have been times when the provider will submit multiple appeals. And what happens when the provider submits multiple appeals, we have to acknowledge the request each time it comes in. So there could be times when a member may receive multiple letters acknowledging that appeal was received because the provider is submitting multiple times. If you go to the next slide. And this is the appendix. And I just wanted to go over the next slide in the appendix just to give you a breakout total by volume for reason codes per year and by product specific for each line of coverage. So let's go one more up. Here you go. So this is a breakout from 2020, 2021, and 2022. This will give you an overview of the type of appeals that were filed year over year. So in 2022, if you look at the type, the first one coming in with a total of 64 appeals were for referrals. The next one below coming in at 53 was for criteria not met. Inpatient admission to follow with 42. Durable medical equipment with 15. And then diagnostic testing with 12. Does anybody have any questions? The rest of the information is also in the appendix. We did break it out by product specific, so you can take a look at all of your different HMO plans and PPO plans, the select HMO. It'll show you the percent of how many calls came in for that plan, how many were
One question after
resol. Yes,
Go ahead.
Yeah, so I look at the appendix, I see the number here. And what was reported by the gentleman, he's not here, that was asking all of these here today. He asserted it was that 65%, that's the number I recall him saying. I'm just trying to look at the notes that said that are appealed. I look at this, doesn't come close to 65%. So how does he get that confused? Or is he talking something separate or just one particular category? That rate of 65% of overturning.
well, this is your total population. So is he looking at a percentage based on his own appeal submitted?
Well, he individually made an appeal, but his own research, and I assume he looked at the I don't want to make an assumption. He made a report that about 65% of those appeals that you all deny get overturned. I don't see that reflected here.
Right, yeah. and this
Well,
is
because
on
he
that
would,
is-
right.
Right, so we're not sure where his information came from, that percentage.
Yes, ma'am. Did you hand up? Oh,
Well, I was gonna say, I'm not sure if it was pointed out, but on the slide that's on the screen now is the year after year.
Yeah.
And then the middle part is the resolution over which are not felt per year. It's close to that figure, but still not there.
And then I have a question, was his problem resolved?
Yes, it was resolved prior to the meeting last month,
Favorably for the member?
correct?
And the question is why was it changed? Well, before it was denied, and then you left to again, was changed. What caused the company to change their decision on this issue?
I can't speak to the specifics of
No,
that
I know.
number, right? But we use clinical guidelines to make these decisions.
Mhm.
And by looking at the clinical data, the decision was made in the member's favor.
But when he submitted his, claim or whatever initially, it was denied.
Yeah, Natalie, can you hear that question?
I heard, yes, I heard the question. So multiple appeals come in, and if the information that is submitted currently doesn't meet the medical criteria or have enough clinical information to support the request of the appeal, it can be denied. And it will be denied with the information stating that there was not enough medical information to overturn, and additional information would be needed. So it would be us going back and looking at the appeals that were submitted. Was the information that was requested for his request received in order to be reviewed by our clinical team and our medical directors? If the information that was requested or needed in order to approve that appeal was not received, then a denial would have been sent out. And the request would have gone back to and stated in the letter that the information received to review this appeal did not meet the clinical criteria or the medical guidelines. If information comes in after the fact, and if it is a provider who is appealing on behalf of the member, if they're changing something in their initial request or appeal that was submitted, that could change the review of how the medical directors are looking at it because the medical information submitted is different or has changed from the initial appeal, that will drive an additional review and that could turn into a different determination. So it sounds like that's what happened in this case. If an appeal was coming in and it was denied multiple times prior to it being approved, there was additional information that was submitted or the criteria that was submitted was changed from the initial submission, and then it was reviewed, and then they went ahead and approved the appeal based on the new submission, based on the new information that was received.
So if I look at this on your report, pre-services, 218 total cases, 178 upheld, 39 overturned. So that's more than 60%. So I don't know whatever. I understand your review process, but if I'm a member, the 218 members, their first response is a no. That's what that means, the 178. Am I reading this right? 218, 178 were denied. That's a no if I'm a member. Maybe that's where he gets his 60% number. This is higher than 60%. Is that
I
just
wouldn't
standard
know.
procedure?
Yeah, I wouldn't know where he's getting his percent from because this is
I'm looking at your
specific.
report. I didn't know what your report is. Am I reading this correctly?
You're reading it correctly. So 218 pre-service and there were 179 upheld. So that means,
Which means that the request or appeal was denied initially. That's what the 178 means, right?
correct.
Okay, that's more than 60%. That may be where he's coming from. And if I hear that as a member, your first response to me is no, then that gives me pause as it did to the member. I guess that would be my concern. And I understand the reasoning why you more information needed, all the reasons you've given. I understand that. But maybe that's where he's baselining this from. I don't know. And he's not here. That's why I was asking.
Right. And I don't know where he's getting that either, because we don't share this information with the members. So he may be looking at the amount of appeals that he filed individually for
I
himself.
will say he is an attorney, so I'm sure he had he can find the information, but I don't know. Chad, you had a question?
Yeah, can we go back to like 2 slides ago? It's a light blue. The next slide, please. So if you can look at the second group of numbers here, I'm assuming that it starts with resolution overturned, upheld, that those 3 rows dated 2020, 2021, and 22 by column. So all these are member driven in some way or the other, right? This is, correct me if I'm wrong, but basically these are, if you drop down to requested by and add up the numbers, they roughly equal the numbers here. So I noticed from what I'm reading, if I'm reading it correctly, roughly 55% in 2020 of member initiated claims were overturned versus 45 being upheld. I'm looking again, the column for 2020.
Correct.
That just seems like a lot of, and this is all member driven. So they've had a claim that's been denied initially, and 55% of the time, over half, their claim was overturned and they had access to care they were otherwise denied, correct?
Correct.
Okay. And then that seems like a very high number for me. And I don't know about your peers, but it just seems to me to be a number that would cause me concern. If you go to 2021, it gets a little bit better, but then in 2022, this changes drastically. I was wondering if you could speak to the total volume of denial claims going down dramatically. And maybe just walk me through these 3 lines so that we can understand it.
So I think for 2020, just due to COVID, there were a lot of appeals that came in that we overturned just because they were going to providers for COVID testing and COVID reasons. So for 2020, that year is an outlier year. I really would have to go back and research the data and look to see the type of appeals that came in for 2021 versus 2022. I pulled the percentage numbers, but I didn't deep dive into the actual cases itself to do the root cause analysis to provide that information. But I can definitely do that and get that information back to Kristen so she can present that to you so you can have a full story of what that looks like.
But if you might, and I'm not trying to dwell here, but in 2021, there's roughly 460 member driven, either on behalf of the member himself, an authorized representative, or a provider on behalf of the member, 460 claims of denial of care that were appealed. And over half of those were overturned. And then in 2022, and this is post-COVID, right? That number drops to, half of that. And I'm just wondering if we should assume that the instances of denial of care are dropping, or is this a result of some other policy change?
It could be that the number of appeals are dropping. I would have to do the root cause analysis. There was also, the volume, you can see it totally was lower, but I would have to do the root cause analysis and take a look at the appeals to see what type of appeals were coming in from 2021 versus 2022 to give you that exact information.
Should we be alarmed that over half of the appeals are overturned ultimately?
When we look at them, I will state this for the city of LA. There are some members that repeatedly submit appeals on a weekly basis where we have received, I want to say maybe 10 appeals a month from individual members, and they are in these numbers of overturns and upholds because they're appealing the same thing.
Yeah, just one other thing. I think it was said, I think the root cause analysis is really necessary to determine, but excuse me. I will say this, that I've worked in the medical policy area of our company as well, and sometimes we monitor it closely. So if we see a certain procedure is being denied quite a bit, right? We'll have a denial and that deny rate's high. Our medical policy team does go back and reevaluate our policies and guidelines. So it could be, for example, that maybe this one area, one procedure was being, authorization requested. We were denying a lot, excuse me. And then over time, our policy changes and we look at the evidence in a different way. And that could be then the denial rate could go down quite a bit. So it could be that dynamic as well, but we would have to really look at the root cause, but sometimes that happens. Does that make sense? That the policy changes over time. It doesn't stay stagnant. Every quarter they look at it and that might make it more approvable under certain conditions.
But
Do we know, like the percentage of denials that are not being appealed, or I'm sure you track the total denials, right? And then you know how many are being appealed. Do we know what percentages are not being appealed?
Yeah, really like the appeal rate for a certain procedure. What's the appeal rate? The denied, how many of them are?
And
I don't know if we have that.
Like, I mean, I'm assuming that when they get a denial, it's clearly written on whatever they receive that they have the right to appeal.
Yeah.
And
there is a process too, just want to point out. So a denial takes place. There's the opportunity for the doctor, a peer-to-peer call. So that goes through that stage. So there are different certain stages and levels of appeal that goes through. And we really try to do everything we can to approve things, right? We don't certainly want to go if it's not medically, no medical evidence that this is the right thing to do. We don't want to approve that, but we really try to go out of our way. Sometimes there's not enough evidence from the doctor's office. Sometimes, the peer-to-peer takes place, which is great. So the doctor can really make their pitch, tell us, do we miss anything? So we do go through it. And then at the end of the day, there always is this chance for an independent medical review. So outside of Anthem, an independent doctor can look at the case too. And whatever that decision from that outside agency, we abide by that. So we do try to go through it and treat everybody fairly. But I guess the last point I just make, we do look at these policies really on a quarterly basis and try to make adjustments as necessary. Hope that helps.
are there timelines that you have to adhere to or?
Yeah. And then just to add to Natalie's point, we do have a few, what I would consider sort of frequent flyer members that appeal quite often that aren't necessarily valid, not Marlene. That wouldn't really be considered a valid appeal. So these numbers, I think, are inflated because of some of those frequent flyers that are higher than
Correct.
from our other groups. So I think, between COVID making more exceptions in the midst of a pandemic and, what Dr. Pryor shared in some of these frequent flyers, the numbers look higher for those prior 2 years.
One question I have is like personnel receiving a lot of complaints, inquiries about this issue. Is this normal with Kaiser, normal with, Anthem or whatever?
This does not exist in the Kaiser format as much because Kaiser is completely integrated. So it's a completely different scenario. We do experience a few members that come to us, but we can only refer them back to, and the member advocate is the one that's fielding all. Going in our office with an Anthem employee is leading the members in the process.
And can our consultant tell us if this is a normal percentage or whatever based on other, experiences they've had with other cities and, businesses? Is this normal with Anthem or with someone else that provides similar services?
We can ask them to look into that.
Yeah. It's a very good question.
Thank you.
Thank you.
Natalie.
You're welcome. Thank you.
All right, thank you very much. Agenda item number 8, committee report, human resources and payroll.
Let's get paid.
I'll make this really quick because we're at time. The most important thing out of this report to say is that we're in the middle of end-to-end testing. Where there's 4 cycles. Cycle 1 is concluding now. Our staff is going to be extremely busy with cycle 2 and 3. So we expect services to be impacted and how we're being able to deliver, the timeliness of us to be able to deliver services, as all staff are going to be heavily involved in testing over the next few months. We're going to do our best to be able to minimize the impact, but it is going to be a lot of work for us to be able to take care of cycle 2 and 3. That is the important thing that I want to say from this report. Any other questions?
What would
What would an impact look like to our members?
Delay in responses. It's our staff that are handling the more complex issues. So the LifeWorks call center will not be impacted. They're not going to be involved in any testing. It's only going to programmers on the vendor side, but our staff that's heavily doing payroll and other options. We also are the ones that are taking care of those higher level issues when instances get involved. We're the ones that are managing the responses on the email that we advertise and other services like that. So it'll be delay in that aspect, potentially. That's still undefined. They keep on moving the dates. So, but it's expected for over the next like 3 or 4 months.
Thank you. No other questions, comments? All right. Next, I include an item, request a future agenda item. Well, at least one. I think I'd like us to start the process of approval for the IFB conference.
Yes.
At our next meeting, if we can.
Oh, yes.
Agenda item. Okay. And then we have our next date scheduled for May 4th. And then June 1st. Any other comments, thoughts? Listen, if not, we'll entertain a motion to adjourn. Second it, and thank you all. Have a good afternoon.